All right, so how often does hypoxia, particularly transient hypoxia, occur during an intubation? And then let's talk about this concept called pulse rate reactivity. All right, so this was a really nice study that said we're only going to look at TBI patients, and we want to see how many of them have a desaturation defined as a pulse ox less than 90 or a drop in your pulse ox if you're already by more than 2% if you're already hypoxic. So how often did that happen? Well, in 54 cases of traumatic brain injury that they reviewed, it happened 31 times for 57% of these intubations had a desaturation. So obviously more than half is a lot. Well, let's take a look now at what their pre-oxygen saturation was. How many desaturated even though they had a pulse ox greater than 90 before we began the process? 84%. So that's quite a bit. What was the duration, the median duration, the 50 percentile of desaturation durations? 160 seconds, and the 50th percentile in decrease was decreased by 22%. So that means half of the people had desaturations of more than 22%. And here's the thing that's truly frightening that led me to change RSI to RSD is almost 20% of these patients who desatted went into a bradycardic rhythm. Now, this paper didn't report on how many times that bradycardia led to cardiac arrest. In reviewing our data, I can tell you that it's not an inconsequential number. So these are patients who had a traumatic brain injury that arrested because of what we were doing. And that's something we just can't do. We have to do something different because our fundamental priority has to be to first do no harm. So interestingly, if we're seeing this, if we're seeing hypoxia in 50% or 57% of all intubations, 84% of intubations with patients who initially were not hypoxic, and it's lasting this long, and 20% are actually ending up with bradycardia, how often is that known? And to the paramedic at the time, and it turns out not all that often. After the intubation, medics filled out a survey. 84% of those patients who desaturated, the medic said this was an easy intubation. There were no problems with it. To be very clear, they are not lying. They just were not aware of it. And again, I think that is a function of our adrenal. All right, to give you an idea of what's going on here, you have a graph like this, and this is a theoretic graph, but it shows you some concepts that I'm going to talk about later with real data. So this is the pulse oximetry data up here, and you'll notice it's coming around 95%, and then it drops off suddenly. It drops off at about the same time that the heart rate drops off, almost as though the heart rate is responding to the hypoxia. And then down here on this line, you have the end-tidal CO2. Now in this study, their end-tidal CO2s were only in line, so they had 0 readings until the patient was intubated. So you can tell what's going on in that area right there. All right, so here is another theoretic graph to give you an idea of what's occurring. So this is percent saturation plotted against time, and you'll see when we initially get there, the patient's around 93 or so. We attach a non-rebreather, and we get their sats up to around 100%. Then we induce apnea with paralysis, and we go to intubate the patient. Here is where we're doing the laryngoscopy. The tube is placed here, and then the pulse oximetry goes back up when we're ventilating through the ET tube. Now, the interesting finding that we're going to talk about later is frequently this low point is actually after intubation. So that's not what we expected. So how often does a desaturation occur what is the likelihood of the desaturation occurring based on your oxygen saturation immediately before intubating? Well, if your oxygen saturation immediately before intubating was less than 90, 100% of those patients had a desaturation. Now, that is a desaturation of more than 2% decrease from what the baseline was. How about if your pre-intubation sats were 92, 100% of patients desaturated? How about if they were at 93%, 100% desatted? And now you'll notice when you get to, now there just were no patients in the study that had a SAT of 94% prior to intubation. But if you look at the patients who had a SAT of 95, 96, or 99, the chances of hypoxia were much less. And this gives you a good idea about the importance of pre-oxygenation. This gives us a curve that we are kind of familiar with in a different fashion. We're familiar with the inverse of this curve, the oxyhemoglobin saturation curve or dissociation curve. And what we know is that as your PaO2 increases, your oxygen saturation increases. And there's a certain point where that increases really quickly, and then going in the opposite direction decreases really quickly. Well, that's nice, but that's not what we're used to looking at. We're used to looking at pulse oximetry. And what we find is that if you make a patient apneic at time 0 and just watch what happens to their saturation, it will gradually decrease. But then as it hits a key point, so right around 94, the slope of this decrease increases. When you get below 92, it gets going really fast. And by the time you get below 90, you are now off of the cliff and you're in free fall and your saturations drop incredibly fast. So that's the reason we need to begin our intubation attempts when we're up here, not when we're down here. Now, I want to remind everybody why we have such an emphasis on first pass success. Dr. Sackles did a great paper here that mapped out the percent of adverse events based on the number of attempts. And if you look at this graph, you'll see this blue line here is the percentage of patients who had any adverse events, at least one, based on their number of attempts. So there were about 14% of patients, I think it was 14.7, who had an adverse event on their first pass. So the intubation was successful on their first pass, but there was still about 14% of patients who had a desaturation. That number goes up to 47% at 2 attempts, and you look and see that you're around 64 to 65% on 3 attempts. So that number goes up very, very rapidly. And the largest, so these separate curves here just indicate what the adverse event was. And you'll notice that the biggest adverse event here is desaturation. So the more attempts you take to get the tube in, the greater the likelihood that they will desaturate and have a bad outcome. All right, so we keep talking about this pre-oxygenation. Why is this important? So we know that we want to increase the amount of oxygen in the body, but it's helpful to understand how we're doing that. The primary way we're doing it is by displacing the inert nitrogen that's saturated in their blood. So nitrogen makes up about 78% of the atmosphere and about 78% of the gases in our blood. It doesn't do anything other than just occupy space. If we can get that nitrogen out of the blood, we can replace it with oxygen so that we are increasing our oxygen stores, our reserve. In doing so, we're going to fully saturate all of our hemoglobin molecules. And the reason we want to do that is we want to prolong our apneic period before the patient desaturates. So we want to be able to increase their oxygen saturation above which, to a point above which they are less likely to desaturate. And the higher we get that up, the longer it's going to be before they desaturate. So this is called pre-ox. Apneic oxygenation, where we're using the nasal cannula while we're intubating, it's called apneic oxygenation or APOX. These are both 2 components that we have to do in our DSI. So, and both of them are absolutely 100% mandatory. If we're going to intubate, we're going to do it right. We're not going to hurt people, and we will do both of these steps. So ultimately, the reason we're doing pre-ox and apneic oxygenation is we're buying more time to achieve our first pass success, and hopefully that concept makes sense. All right. This is just a theoretic graph, but conceptually it will show you the longer the patient is pre-oxygenated, the more time the patient has before they begin to desaturate. Now the key is no matter how long you pre-oxygenate them, Once they begin to desaturate, they're going to desaturate at roughly the same degree or the same rate. So you'll notice the slope on all of these curves is the same. The difference is how long it takes before they desaturate. So this is a patient who became apneic and had no pre-oxygenation, and you can see they desatted very, very rapidly. Whereas with this patient, they were pre-oxygenated for about 30 seconds, and they lasted much longer before they desatted. And with each increase in the duration of pre-oxygenation, they bought themselves more time before they desatted. So pre-oxygenation only changes this flat plateau before they drop off the desat curve. The rate that they're falling once they go off the edge is the same. Apneic oxygenation, on the other hand, both increases this and decreases this. And that's the reason we have to use both. Well, let's say they do desaturate. You have to abort your intubation attempt and begin to bag them up. Well, our adrenal glands are going to kick in this setting, and we're going to bag them very, very rapidly. We don't need to do that. This graph shows what happens if you take someone with an oxygen saturation of 80 and ventilate them again at different rates. And the green rate here is at 40 times a minute, and then the red rate is at 5 times a minute. And you'll see that you get resaturated with most of these graphs, most of these rates, at almost an identical period of time. So we see that we're not buying a whole lot of additional time by hyperventilating the patient like an adrenaline junked out mannequin. So getting all jacked up on Mountain Dew and ventilating at 500 times a minute isn't going to get the sats up in a significantly faster period of time. So if it's not helping us, is it hurting? Because it will get you there a little faster. Well, is that a good thing? Well, you have to weigh the benefits and the harms, and we know that hyperventilation has some significant impacts on decreasing cardiac output. So these are patients who are likely hemodynamically unstable. They are certainly at risk for becoming hypotensive and desaturating and going into cardiac arrest from bradycardia. So hyperventilating has a real cost, so we don't want to do that. So there is a limited benefit and a real known harm. So that's the reason when we go to bag them back up, we don't do it rapidly. This slide is just a reminder. This is the oxyhemoglobin dissociation curve that we all know and love, with pulse ox over here and alveolar oxygen pressure here. The patient is at low risk for desaturation if they start off well saturated. So this is a PaO2 of around 90, which corresponds with a pulse ox somewhere around 95. So if they're above that point, and I think the number comes out to be 94 or greater, if they are above this point, you have plenty of time and the odds of them desatting during your intubation are pretty low risk. Whereas if you're between 90, say 3 and roughly 90, you're at high risk. And again, we saw that data that said 100% of patients with a SAT between 90 and 93 desatted. Well, if you're already hypoxic when you begin the attempt, you're on that steep end of the curve, and your SATs are not only not going to come up immediately, they're going to drop, and they're going to drop dangerously fast. Now, I just want to put this back up because right now this is my favorite paper of the year, even though this was published in 1959. This demonstrates the degree to which apneic oxygenation works. Remember, what we're doing is putting a real nasal cannula in the nose, cranking it up after sedation to 15, 20 liters, whatever the cylinder goes to. And we're doing that during our intubation. This is a wonderful study that took patients who were undergoing normal surgery, they paralyzed them, sedated them, intubated them, and then just put oxygen tubing down the ET tube at a high concentration and said, let's just see how long they go before they desaturate. And you'll notice they went a long time. These numbers are in minutes. It's 30 minutes, 45, 55 minutes, 53 minutes. And what we notice is they never desaturated. So apneic oxygenation will work very, very well. That is not, however, to suggest that we should not ever ventilate patients. We clearly need to, because when you're going 53 minutes, some bad things are happening. So if you carry this around, what we see is a CO2 of 250, incredibly high. And you'll notice that corresponds with a pH of 6.72. That's phenomenally dangerous. The patient's physiology is not going to tolerate a pH that low. So that's a pretty bad thing. But from an oxygenation standpoint, we are oxygenating quite well. Apneic oxygenation clearly works.